Good morning. We'll get started. I know there are still some people grabbing coffee, but we'll get started so we can come close to end on time and have a rich and fruitful discussion. Thank everyone for coming for this special summer grand rounds. This morning's presentation is being held in conjunction with and partly sponsored by the support organization for Trisomy 1813 and related disorders. I've had the unique privilege and honor of being the medical advisor for SOFT since it was created here in Utah by two moms of girls with trisomy 18, and that was in 1980. The purpose of this morning's event is to delve into the complex and sometimes controversial issues surrounding the decision of cardiac surgery in infants and children with these conditions. After my brief introduction, we will hear from four speakers. Dr. Menon, our own pediatric cardiologist who's worked hard on this topic. Dr. Benjamin Wilfon, our keynote from University of Washington, who is a pediatrician and ethicist. And two parents, Faye Kaufman and Mark Cabana, who have their daughter Morgan with trisomy 18, who did have heart surgery. We'll hear more about that. But first, a story. One of our own children from Utah. This is Ashton, who has full trisomy 18. She's pictured here during the second year of her life. This was just before she had her VSD surgery here at Primary Children's. Her parents are the co-organizers of the meeting that's now occurring this week. She was born small for dates and had physical features suggestive of trisomy 18. I saw her as a newborn. The neonatologist and I confirmed the clinical diagnosis, and we got chromosomes to show that she had complete and full trisomy 18. She had a G-tube placed when she was just under a year of age, and after a lot of discussion with increasing pulmonary hypertension, but not irreversible, she had heart surgery just before her second birthday. To my knowledge, she is one of four children in Utah with trisomy 18 who have had heart surgery, two with pulmonary bandings, another child with a VSD repair, and Ashton. Ashton is now 15 years of age. Here she's about 13, and she's a pupil at Harvickson School. So let me say a few more words about trisomy 18 to set the stage after my story, which hopefully also sets the stage. Trisomy 18 and 13 together have a total prevalence, that is live-born, stillborns, and terminations of pregnancy, of 1 in 1,800. That means that 2,000 families a year in the U.S. experience the knowledge that their developing baby or their infant has trisomy 18 or trisomy 13. Actually, you can see how high that number is, higher than neural tube defects, higher than cystic fibrosis, higher than many of the not-so-common disorders that we take care of here at Primary Children's. So among chromosome syndromes, or among syndromes in general with developmental disabilities and multiple congenital anomalies, as many people in the audience know, trisomy 18 and 13 are particularly unique. First, there's a notable increase in congenital malformations, especially of the heart, where 80% of children with trisomy 13 have a structural defect and 90% of children with trisomy 18. In addition, there is a known increase in neonatal and infant mortality, and I'm not going to go through those figures today in detail, I'll just summarize them. That's unique among many other syndromes we take care of in genetics, neonatology, and cardiology. And thirdly, the outcome of surviving infants is notable because of the significant developmental disability, which again, we won't talk about in detail today, but at least bring up. I do refer you to a review article I helped write in Current Problems in Pediatrics and also in Journal of Rare Diseases. So trisomy 18 and 13 have this natural history of this increased mortality. So the population studies show that 50% of children have died by a week of age, and about 5 to 8% of children do reach their first birthday. So by no means is this condition so-called lethal, as has been discussed in the past and will be discussed again today. The reason for the death in those who do pass away is quite complex, and you can see some of the listed variables. There are 10 population studies that have been done in the last 20-plus years throughout the world. And again, my purpose today won't be to summarize those studies, but I gave you the key figures already. Again, of about 5 to 8% of children will reach their first birthday, but many children do not live in the first year of life for reasons I just mentioned. It is notable that in the recent studies, there has been a trend toward increased survival, whether that's better numbers and better registries, or some trend toward intervention, I don't know for sure. Here is one of those studies from Denmark, just depicting for you the mortality figures of both 18 and 13, and if you look at the graph, you'll see that figure of about half of children pass away in the first week of life. So there has been a lot of controversy around care, and as one of my colleagues once said, there's almost a palpable tension in the field of many of our specialists in pediatrics surrounding this idea of perhaps we're doing too much, or we should be doing all we can to help this particular baby come through. The conventional wisdom for the last 3 decades, in my experience, has been non-intervention. Now, what some people might call pure comfort care. But in the last 7 years, and I think the last 10 really in a paper by Dr. Wilfon, there has been an emerging dialogue and much more discussion in the pediatrics and bioethics literature. I think some of this was spurred by this paper in pediatrics by McGraw and Perlman, which it turns out that Shaji and Ben will both mention, and I won't discuss in detail. Bottom line, over half of New York neonatologists indicated they would not resuscitate a baby with trisomy 18 in the delivery room with the known diagnosis. This is the title from the paper I wrote in Perspectives in Pediatrics, Current Opinions in Pediatrics, which I turn your attention to, in which I did discuss these questions. Are trisomy 18 and 13 uniformly lethal? No, they're not. I already mentioned that. What is the neurodevelopmental outcome? We won't discuss that today in detail. And the basis of the controversy will be what our next 2 speakers will focus on. So again, I'll close on this slide without going through the details for the moment, but there have been a number of studies in the last 10 years on cardiac surgery in trisomy 18 and 13. We actually did perform a study in SOFT, which I published in a chapter, but now is being updated in a project that Shaji, I, and Ann Barnes, who's in the audience, are working on. But this will just lead me into the next discussion for Shaji, who's also going to talk about the SOFT registry. So I would like to introduce our colleague, Shaji Menon, who's been helping me tremendously over the last few months in preparation for this talk, as well as the clinic. And let's see, here we can get you into the next step there.
Thank you, John. And I would like to thank the SOFT organizers for inviting me to give this talk. And so I don't have any disclosures except for the fact that I am not an expert in trisomy 18 or 13. I'm not a cardiac surgeon, but I'm a cardiologist. So I basically recommend cardiac surgery, but the surgery is actually performed by surgeons like Dr. Eckhauser, who is sitting here. So I would like to start with a case and get your thoughts. So you have a 4-month-old with trisomy 18 and a large VSD who's hospitalized in the infant medical unit with bronchiolitis and CHF. In counseling the family who wants heart surgery, your best advice will be, A, cardiac surgery is going to prolong the suffering without any benefits. Cardiac surgery is extremely high risk, and the surgical mortality is likely more than 75%. Cardiac surgery may be an option and may improve survival. And the last option is it's unethical to do cardiac surgery in patients with a lethal disorder like trisomy 18. So I asked the same questions a few weeks ago when I was talking to the nursing council. And I won't tell you what the response was, but let's see, this is more of an educated audience with very senior members here. So, okay. So there you go. 83% thinks that cardiac surgery may be an option and may improve survival. When I asked the same questions before, actually the audience were really split between these four choices. But obviously this is a more educated audience, but still there are people who think that it may be unethical. There are people who think that cardiac surgery may be extremely high risk and it's basically prolonging the suffering. So let's look at the data that what we have. So my understanding of trisomy 18 was limited before I met Aaron Peterson, who I had the distinct pleasure and privilege of taking care of for the last 5 years. And he's right here among our audience. As his mom would say, he is not only compatible with life, but is compatible with joy. So if you look at the incidence of cardiac defect in trisomy 13 and 18, as John mentioned, it's very high. About 90% of them will have heart defect. And majority of them are common defects like ASDs, VSDs, and polyvalvular disease. However, about 10% of them will have more severe heart disease like double outlet right ventricle, AV canal, or single ventricle defects. It is important to know that majority of these early death in trisomy 13 and 18, I'm talking about the early neonatal death, are not due to cardiac defect. There has been a paradigm shift in the way we take care of these patients with trisomy 13 and 18. We have gone from do not resuscitate to full resuscitation, from no cardiac surgery to increasing number of cardiac surgeries performed across the country, and from earlier papers showing no benefits of cardiac surgery to better survival with surgery in select population. However, what we find that there is still a significant proportion of healthcare providers who think that it is futile to perform cardiac surgery in this group of patients. This is our fetal heart center or fetal center experience of trisomy 18. Since 2007, we had about 17 patients, of which most common defects were VSDs and tetralogy of Fallot. Fetal demise or stillbirth happened in about 20%, postnatal death in 82, of which 12% or 2 decided to go or pursue hospice. None of the cardiac surgeries were performed in this group of patients. We have performed since in last about 10 to 12 years 4 surgeries in patients with trisomy 18, 2 with VSD repair and 2 PA bands, and all of them survived the surgical intervention. If you look at data regarding trisomy 13, since 2007 we had 11 fetuses. The diagnoses were much more complex: double outlet right ventricle, hypoplastic left heart, and such. Fetal demise or stillbirth in 27%, postnatal death in 73%, and then no cardiac surgeries were performed in these patients. Now I'm updating the data that John talked about from the SOFT registry. So this is a parent support group, and the registry is patient-reported outcomes, and it starts from about mid-1990s and goes up to the present time period. And there are 21 patients or 21 parents reported outcomes in trisomy 13. 20 are from US and 1 is from Canada. In trisomy 18, there are 105, and these are all patients who underwent cardiac surgeries. 101 is from US, 3 from Canada, and 1 from Norway. The type of surgeries that were performed most commonly were VSDs, 24 and 42%, followed by tetralogy of Fallot or double outlet right ventricle, coarctation, PDAs, BT shunt, PA band, and ASD. So let's look at the outcome. So if you think about cardiac surgery, it can either be a complete repair or a palliative procedure like BT shunt or a PA band, or a CAT procedure to do some kind of intervention, for example, closing of a PDA or closing of an ASD, pulmonary valve or aortic valve interventions. So majority of them were complete repairs, 76%. This is in trisomy 13. 10% were palliative and 14% were CAT procedures. And if you look at this families defined success or successful or unsuccessful or unknown. So basically, if the surgery was successful and the patient survived, they described it as successful. There was also a narrative that we went through. Majority of surgeries were successful, 97%, and 3% the outcome was not known. If you look at trisomy 18, again, 59% were complete repair, 14% were palliative, 13% CAT procedures, and then 9% were diagnostic CATs, and 5% were unknown. Again, 89% of surgeries were defined as successful by parents, 8% unsuccessful, and 3% were unknown. We just finished looking at the Pediatric Health Information System database, which is essentially a database of 40+ freestanding children's hospitals in the United States, and it's an administrative database of inpatient admissions or inpatient contacts. And there were 81 patients with trisomy 13, and 195 patients with trisomy 18. And as John mentioned, if you look from 1999 to 2014, there is a trend towards the increasing number of interventions in these patient population. Going more in depth into the data, majority of survivors or patients who had cardiac surgeries were females, no surprise there. Majority of surgeries were performed in South. Baylor or Texas Children's performed a lot of these surgeries, 46% in both trisomy 13 and 18. If you look at in-hospital mortality, this is mortality before the patient goes home, is about 26% in trisomy 13 and 13% in trisomy 18. If you look at median length of stay, it is about 17 in trisomy 13 and 15 in trisomy 18. This is for all surgeries. What are the type of surgeries that are being performed? Again, majority of them are repair of VSDs or septal defects, 33% and 62% conotruncal defects. Next, 27, 32% coarctation, and there are a smattering of other surgeries. Now, if you look at how many surgeries are performed under cardiopulmonary bypass, meaning by patient is having an open heart surgery where you have to use cardiopulmonary bypass, more likely a complete repair. In trisomy 13, it is 58%. In trisomy 18, it is about 17%. And again, these are the type of defects that are being repaired. Majority in trisomy 18, 39% septal defect, coarctation 3%, BT shunt, which is a palliative procedure, in 11%. And if you look at trisomy 13 data, the septal defect repair is 12%. There are more palliative procedures like BT shunt, 33%, coarctation 8%, conotruncal defects 8%. Now, if you look at disposition of these patients, so what happens to these patients after surgery? As I talked about, majority of them survived the surgery, 66%, and the in-hospital mortality was 13% in trisomy 13, and 66% went home. 8% was discharged home with health services, 12% went home with hospice, and in 1% the data was missing. I'm sorry, this is trisomy 18 data, not trisomy 13. And here's trisomy 13 data. 63% went home, 26% expired. Remember, for trisomy 18, it was 13%, almost double. 2% went home with hospice, and 9% went home with hospice, and 2% went home with health services. Now, these patients, majority of these patients make it through the surgery. What about resource utilization compared to other patients who are undergoing similar surgical procedures? This was an abstract that was presented in 2013 AHA. I have not seen in manuscript. This was from the Kids Inpatient Database. They publish the inpatient data every 3 years, and they looked at 2006 data and 2009 data. There were a total of 35,000 plus cardiac surgeries, of which 14 were in trisomy 13, small numbers, and 34 in trisomy 18. If you look at length of stay, it was about 2 to 4-fold compared to other patients without these defects for similar surgeries, 35 days versus 9 days. Hospital charges were twice or 2-folds compared to the population without these defects. And if you look at adjusted odds of death, it was 4-fold. So now there is a smattering of papers, small studies. This was the most recent one from Children's National. There are papers from Japan that John mentioned, looking at trisomy 13 and 18 interventions. There's a paper from the Cardiac Consortium here, which was published in 2003. All of them show that if you do no intervention compared to an intervention, the survival is better. So this is no intervention, this is prostaglandin, this is in trisomy 18, and this is with surgery, and as you can see, the survival is better. This was the first one, followed by this one in trisomy 18 and 13. Non-operated kids are down here. These are all patients, and operated kids are up here. So clearly there is improved survival. Now these are select group of patients. These are not all comers for sure. The Pediatric Cardiac Care Consortium, it's a consortium of 48 centers in US, Canada, and Europe. They looked at the 35 infants, and the hospital survival was 91%. This was the paper which most recently came out a few months ago. Again, operated patients had better outcomes. Mortality was 29% in operated versus 50% in non-operated. Similarly, in trisomy 13. Again, these numbers are really small, select group of patients, single center experience. So Dr. Wilfond is going to talk to you about a survey he performed in this patient population and looked at the patient's experience with healthcare providers and what they hear when they talk to healthcare providers. And he will show you that a significant number of families or proportion of families hear these not infrequently from healthcare providers. And these are things that you should not be talking about or saying to these families. One, incompatible with life or lethal. Obviously, it is not true. It is false. Anyone can Google it and find out that they are compatible with life. They live a life of suffering. It's not true. They are like in a vegetative state. Not true. Clearly, this is Aaron Peterson. This is a vegetable, and you can see him. Okay. He has emotions. Clearly, these patients have significant cognitive impairments. They have limited interactions, but they do have positive interaction with the family. Right, okay. These children are replaceable? No, they are not. It destroys families. There is no data suggesting that having a child with trisomy 18 or 13 increases the number of divorces or issues in the family. Nothing can be done for them. Clearly not true. Even if we are doing hospice care, that is something. Even if we are providing compassionate care, that is something. But there are issues. These are patients with high mortality and morbidity. And taking a quote from one of my favorite movies by late Robin Williams, our job is improving the quality of life and not just delaying death. And so we have to balance the issues between parental wishes and benefits of surgery, compare that to the risk and burden of treatment, especially because we believe in do no harm first. But fertility of care decisions are really hard to make, especially when you're going against patients' wishes. And it's really a crisis of conscience. There are social justice issues, fair distribution of scarce healthcare resources, and there is quality of life is a value judgment. And this is best made by patients and families rather than by physicians. And there is a shift towards parent or patient autonomy in healthcare compared to physicians making decisions for the family. And whenever you face a patient with trisomy 18 or 13 and you have a difficult decision to make, engage parents, colleagues, experts, and ethicists. They can help you, make a right decision. So I will end with this slide. How do you make decision in trisomy 13 and 18 with cardiac defects? These are some of the broad principles. Full disclosure of all treatment options, limitations and outcomes should be discussed. Individualized care, not universally lethal or futile. Respect patients or parents' wishes and autonomy. Cardiac surgery is not often emergent. In fact, it can often be delayed to postnatal period. Pulmonary hypertension may obviate need for surgery in shunt lesions, especially if they have a VSD or an ASD and they have severe pulmonary hypertension, they don't need surgery. Catheter-based or palliative surgeries are lower risk. There are increasing number of centers who are offering cardiac surgery in select patient population. It improves survival. There is data to show that. surgical outcomes acceptable, but obviously worse than non-syndromic patients. They do have higher resource utilization, longer length of stay and cost, and be compassionate and an advocate. So I would like to acknowledge John and others who have really helped me put together this talk. Thank you so much.
Thank you, Shaji. So our next speaker will be Benjamin Wilfon. And Ben, let's see if you can help me with the technical. And seeing Shaji's comments on fetal reminded me that I forgot to mention that Dr. Wilfon's visit is being co-sponsored and hosted by Dr. Jan Byrne, our Maternal Fetal Medicine Division. And that was in my notes, but until you showed that, I forgot to mention. So, Ben, I'll let you take over there.
Thank you. It's a pleasure to be here. You really set me up very well with your presentation in terms of what I'm going to talk about, because I'll be elaborating on some of the themes that came out at the end of your presentation. I'm a pulmonologist by training, and in fact, the reason why I have this broad title on the beginning of my talk is because I think about these issues very broadly. The issue of trisomy 18-13 in cardiac surgery is a case in the broader issue of children with profound disabilities and the wide range of medical interventions that we can do. And in fact, as a pulmonologist, I've written a lot about the issues of tracheostomy and mechanical ventilation. And so while I'll begin with a few slides specifically on trisomy 18-13, most of my comments are really intended to be very broad and talk about all types of interventions and all types of disabilities like this. But I will begin talking briefly about trisomy 18-13, and this is the paper that has been previously mentioned by McGraw and Perlman that regarded this survey that showed that 60% of neonatologists would not resuscitate, but 40% would. And this is the comment about the 40% who would, that while there was a consensus that trisomy 18 was a lethal anomaly, we speculate that support for the best interest standard is diminishing in favor of ceding without question to parental autonomy. And they concluded this represented an ethics of abdication, fairly strongly worded description of those people who chose to resuscitate people with trisomy 18, an ethics of abdication. Shaji mentioned that the paper that I worked on with Barbara Farlow and Annie Janvier, which I'll describe briefly. You actually you'll say more about it than I did, because you actually showed that one slide. But what we did is we surveyed around 300 families about their experiences. And again, particularly for those who are parents, know all full well that the experience is different from how it's often described in medical textbooks, how often it's described in the hallways between healthcare providers. However, what those parents also described was often challenging discussions with healthcare providers, perhaps related to the types of attitudes that we saw in that very first slide. And in our paper, we actually commented specifically on that comment by McGraw and Perlman, and said that we think that their ethical analysis is incomplete without parental experience. Quality of life and best interest are essentially subjective. Healthcare providers and parents have different views on what a good quality of life is. I think that's really one of the central issues. There's difference of opinion about how to do this. When we talk about these issues, we can choose to frame it in a number of ways. Quality of life is one way. We could talk about with regards to lethality. We could talk about costs. We can talk about benefits and burdens, and how we frame it may be related to our implicit views about the value of children with disabilities. And that's actually going to be the main theme that I'll be talking about in my next few slides, is really the underlying issue is how do we view the life of a child with a profound disability? Is this a life worth living? Is this a life worth supporting? Is this a life worth putting resources in? And who should make those decisions? And what's challenging is that these words that we choose to use, like quality of life, lethality, cost, benefits, and burdens, can be used to justify those implicit views. I think of all those words, the one that I find the best one to use at the end of the day is the notion of benefits and burdens, which is still complicated. And what I'll do now is just go through each of these and make comments in a variety of ways. So first, I want to talk about quality of life. And I'm going to start, for those that, I'm going to see if any of the pediatric residents who are a bit younger recognize that picture. Anybody of the residents here? I didn't think so. This is Randy Newman. This is a song called Short People that came out now quite a while ago. I encourage all of you to listen to it if you haven't. It's a very serious song, though, but what makes it funny is about short people. It's not about trisomy 18 or 13, but you could imagine you could replace it. And it talks about the social attitudes about short people and how horrible they are and how irritating they are. And, you know, wouldn't it just be better if they would just go away? And so when we talk about quality of life, the idea was that quality of life can be looked at by others as just being horrible. And so for people who are tall, as Randy Newman described, short people had a horrible quality of life. And so the challenge of quality of life that Randy Newman describes is whose perspective do we think about when we talk about quality of life? And the challenge, I think, is that most of the public themselves has very little contact with children with profound developmental disabilities. This is not something we see regularly. Perhaps it's changed a bit now because of the way our school system has really done, in my mind, a very valuable social opportunity for engagement with children with profound disabilities and children as part of the school system experience. But the challenge, particularly in the healthcare system, is we often evaluate the experience of those children from our own perspective, of which we have most people in the healthcare professions have above average cognitive capacities, and so may have less enthusiasm for people with less than that amount of capacity, and also from a distant relationship. Our experience is often related to what we see in the hospital and not what we see at home, and so not from the perspective of the family or the child who is in the position to care for them. So let me talk about lethality. John mentioned this briefly. I wrote a paper about this now about a little bit over 10 years ago with Laney Ross and Tracy Kugler that had the title Lethal Language, Lethal Decisions. And it really has to do with this term lethality, how it's used in pediatrics. And the issue here is that this notion of quality of life I just described by Randy Newman, people won't say that publicly. People won't say people who are retarded shouldn't be living. That's not a comfortable thing to say. People may believe that. They may talk about its quality of life, but there's a better way to talk about its quality of life. We can call it lethal, because it's lethal. There's nothing to do. This is a medical decision. This is not a social decision. So by calling it lethal, it medicalizes what otherwise would have been an uncomfortable normative decision about quality of life. There's other words that we may also try to use to, in addition to quality of life. Sometimes we'll call it suffering. Sometimes we'll talk about family burden. We'll also talk about cost. These are all words that we use to justify, potentially implicitly, this view that this really is not a life worth living. The challenge, I think, is that these unexamined views or implicit views can have an impact on how we not only provide our attitudes, but what information is conveyed to providers. So part of the idea of what was being presented by Sanjay was the whole idea that, in fact, cardiac surgery can have an impact. It's not the case that it does not have an impact, but if a person has a view that this is just not a life worth living, it's going to be hard to be comfortable presenting that view that, well, this may have an impact on survival. Now, let's talk about costs for a few moments. Costs are a critically important healthcare issue, health policy issue. It will only get more complicated in the next coming decade. I don't think that the costs of care of children with disabilities are the primary driver of healthcare cost escalation. There's lots of research on that. Most of this occurs for the adult population, the 6 months at the end of life. The children with disabilities are not the driver of our healthcare system's costs. Costs still are a legitimate concern. The challenge is that cost is often used not as an explicit, sincere, legitimate concern, but as a justification for not providing treatment. For me, the most interesting aspect of this has been I've seen this been justified in a circumstance where the expectation is that there'll be a very short lifespan. We shouldn't do this because this child will only live for a few months. I've also seen it as justified because we shouldn't do this because this person might live for a long time. So in essence, the underlying issue, in my view, is not about the cost itself, but again, how we value those children. So I think the better way to think about this is as benefits and burdens. Or benefits and harms, a variety of ways of talking about this. It's still very complicated. And the concerns still are value-based questions about life, about the resources. And it is the case that people will have different values, and that clinicians may have different values than families will have. I think one of the big take-home points for you is, for those of you in the audience who do have limited experience with children with profound disabilities, look for opportunities to spend time out of a hospital with children who do. And from my own personal experience, that really had an impact on me on changing my views about this. I think this notion of trying to respect parents' roles and how they value their children is very important. It doesn't mean that we do everything that parents say all the time, but we have to listen to them. We have to learn where they're coming from. And I also think that as professionals, we do have an obligation to think about those most dependent and vulnerable in the population around us. If we're not able to speak for those, who else will? So I'm going to end with one final slide. This is actually from a paper I published about a year ago, broadly on the issues of mechanical ventilation on children with profound disabilities. But these are suggestions I have about how to think about approaching families. The first is try to understand what the parents' values and goals are for their family. Having a conversation about where they're coming from, what their views are, what's important to them. Consider whether a parental request is actually against a child's interest, which it could be in some cases, or whether it is a disagreement about values. When there are value disagreements, avoid terms like futility and lethality that obscure those value conversations. It's hard to provide balanced information. Consider involving providers who are involved in long-term care. Consider providing access to families who have had both positive and negative experiences in similar contexts. To me, one of the values of the paper that I presented earlier in terms of the social networks was simply, the purpose of that paper was to communicate to physicians that this is what parents are going to be learning about from their interactions on the internet. And it's important, therefore, to be aware of that, because this is one of the ways that parents will be having information. It is, I think, reasonable to make directive recommendations to families. That might be a recommendation to do surgery. It may actually also be a recommendation not to do surgery. But that recommendation needs to be based upon hearing and understanding what the family's goals are and what the feasibility of reaching those goals will be. And that supporting parental goals, when they do have a goal of life-sustaining interventions, it treats the family with respect and expresses the value of the child in the same way we might imagine we would want any provider to have that same view of our own children. So with that, I'll end.
Dan, thank you. I was reminded in your talk that you were at this podium, about 7, 8 years ago for the David Green lecture, which I know Jeff had something to do with helping, but watching you speak reminded me of that as well. It is a pleasure to introduce our next two speakers. I think we'll probably take the podium together. Is that right? Faye and Mark, who are here for the SOFT meeting, also parents of a child with trisomy 18, Morgan. They'll tell you about her story, and Shaji mentioned Texas Children's, which fits into their story. Mark, I think that Shaji has you up here. So this is
yeah. Hi, my name's Mark Kabinen. This is my wife, Faye Kaufman, and we have a daughter with diagnosed with trisomy 18. She had open heart surgery at Texas Children's Hospital when she was about 8 weeks old. And I'm here to say that she's 18 years old today, and she's the joy of our life. And everyone who meets her, it's just a pleasure. And what we knew at a really young age with Morgan is that she would mean something different to everyone who met her. And I can honestly say that that has been true throughout Morgan's life. So.
Good morning. Thank you for attending and taking an interest in not only Morgan, but the other trisomy children she represents. It's first important for everyone to understand that Mark and I are parents. We're just typical parents, just like those of you in the room who have children are typical parents. We want for Morgan the same thing you want for your children. We want her to be healthy, happy, and to have the best opportunities. We want her to be the best that she can be. The operative statement here is that. It's that she's to be the best that she can be. That's our philosophy, and that's the one that we've carried since the day she's born. As Mark said today, Morgan's an 18-year-old high schooler with an attitude you'd expect from an 18-year-old. And I thought I was going to miss all that. Yeah. As you can see, she uses a walker to make her way around campus at school. She doesn't use words, but she has no problem communicating what she does and, moreover, does not want. She loves to swim, and she just lives a pretty typical life. Thanks to a brilliant neonatologist who once told me he had never seen an infant starve itself, she eats by mouth. If I misquoted you, Dr. Bloom, I'm really sorry. But the essence of this is that those words that you gave us on that mountaintop in Park City one day gave us the encouragement to allow Morgan to tell us, of course it was after several removals by her of her OG tube, that she intended to taste her food. I could give you a list of the skills that Morgan has. I could ask you to spend some time with her and you'd understand her. But what you really have to get from Morgan is a bit of what Mark just said. Oh, this is me torturing her. Evidence. Mark and I are far better people for knowing her. We get it, we understand it. We've figured out through having her, living with her, loving her, that you have to appreciate what you have. You can't blow through life.
Okay, here we go.
I think the music is on at the gym. I'm really into exercise.
This is actually. They're not going to bring. Had her surgery why friends going to school, saying let's work out. Well, Morgan likes it. And it's amazing that she can hop on this treadmill.
What our family, our friends, and sometimes complete strangers have learned from Morgan is that it's not, a person's value isn't what contribution she or he will make to the workforce. It's not how much money they'll make, and it's not how much money they'll spend, either at Neiman's or at the hospital. It's what they'll teach you about the human spirit. And Morgan has certainly taught me a lot about the human spirit. We understood very early on in Morgan's life that it's imperative that our doctors be on the same page with us, that they have the same philosophy to give Morgan the best opportunity she can have to be the best she can be. We didn't want to support Morgan's life artificially. We just wanted to give her every opportunity to show us who she would be. If not for the fast thinking of an OR nurse, we call Nurse Dan, and an open-minded pediatrician, Dr. Dawn, our coach, a wise cardiologist who saw a child, not a syndrome, Dr. Michael Nihill, and a cardiac surgeon, Dr. Charles Frazier, who used his knowledge, education, and experience. Without prejudice, our story would be much different. And these are all Texas children's doctors, as John said. From the time of Morgan's diagnosis, we heard all the scary things. 90% die, they don't eat by mouth, they have kidney problems, blah, blah, blah. We have been told by one geneticist, sorry, John, that their tissue wouldn't repair. He obviously wasn't as smart as you. So therefore, she couldn't have heart surgery. So we heard all those stories. We still just had the objective to give Morgan every opportunity she could be who she was meant to be. This slide pretty much gives you the litany, or most of the litany, of some of the surgeries she's had and what happened with her. She's actually had spinal fusion and foot surgery too. But Mark and I are both licensed professionals. We spent our careers using our education, knowledge, and our training to advise our clients what course of action they might take based on what suits them, their risk factors, their tolerances the best. We don't make decisions for them. And throughout Morgan's life, we've expected our medical professionals to apply the same professionalism. Because like our clients who have to go home and live with the decisions that they make for their actions in engineering for Mark and tax for me, we have to take Morgan home or not and live with the decisions that are made. I have one comment that I hope doesn't offend anybody. Trisomy 18 isn't lethal. The heart anomaly that is the result of the 18th chromosome, that's lethal. But having an 18th chromosome, a third 18th chromosome, that's not lethal. It's up to you.
So anyway, so in all the this is kind of a factual. Morgan again was born on September the 14th. When she was born, she was under 5 pounds. So obviously, that was one of the first signs that something may be wrong with her. She did accept her first feeding, but after that, she, if you will, refused to have that suck, a swallow reflex or reaction. And then we noticed that she had a high heart rate. So one of the things that we did, obviously, was she was moved to the PICU, and we met with a cardiology department at Baylor College of Medicine, where they performed a series of tests, and then they did some genetic testing to obviously try to determine, you know, what was wrong in the issues. And so on September the 20th, about 6 days after birth, she was postnatally diagnosed with full trisomy 18, and obviously they were going to send us home with a preliminary death certificate saying that there should be no intervention. So as great parents that we are, or at least we think we are, we started the search in doing our research, because as parents we're like, okay, what do we do now? And hats off to Faye, she always had a great attitude, but she's like, well, you know, I have a child with a heart problem, and I have a child with 3 chromosomes. So we have the problem is the heart anomaly. So let's address that and let's fix that and move on. Well, in the process of all this, we're doing our research, and I literally took it upon myself to go to the library at Baylor College of Medicine and pull whatever research or whatever documentation I could find on trisomy 18. And both Faye and I read this. In the process of doing all that, we ran across the geneticist at TCH gave us a Xerox copy of the book, and I'm sure some of y'all have probably seen it floating around here, that was written by Soft. Ann Barnes is obviously one of the authors of the book with John. And I read this book. Ann is the author. She's with us today. So anyway, and so it was funny because by the time I finished reading this book, when I brought it home, Morgan's still in the PICU at this time. It's probably, you know, day 5 or day 6 or whatever. And I remember reading this book, and I got up from reading this book, and I thought to myself, well, okay, what do you do? And as a parent, you don't do anything. You do the same thing you would do as if she didn't have a heart anomaly and she didn't have trisomy 18. She's my little girl, I'm her dad, I have to take care of her. As parents, we made the decision that we're just going to treat her like a normal kid. And that's exactly what we've done her entire life. And so as a result of that, she came home from the hospital 10 days later with an OG tube and hospice. She went into heart failure on October the 31st. We took her to Texas Children's Hospital. And it's kind of an interesting story because Faye mentioned earlier that is the, if you will, the experience, the wisdom, and really the knowledge of the trauma nurse at Texas Children's Hospital who, and I think in both of our opinions, probably really saved this child's life. What was interesting in all of this is that when Morgan's laying on the table in heart surgery, or in heart failure, and there's all kind of doctors running in and out of the room to figure out what they're going to do, this nurse is listening to this story that Faye and I are telling about Morgan's history. And in the process of all this, Morgan's laying, I'm not supposed to move from behind the podium. So Morgan's laying on the table, Faye and I are sitting here, and this guy has got his back to us the whole time. And what he's actually doing is he's setting Morgan up to go upstairs in the intensive care unit because he knows she's in heart failure. So he's setting her up to be intubated. No one gave him instructions to do this. He's doing it all on his own. So make a long story short, he gets her all set up. We're getting ready to wheel her out of the, I forgot what you call it, the emergency room, the trauma room, and take her upstairs. And in the process of doing this, one of the residents stops him and says, Nurse Dan, you can't do that. You don't have instructions to do that. And he says, well, I'll tell you what. If Dr. Don has a problem with that, tell him to come see me. So he looks at us and says, Mom, Dad, follow me. He takes us around to the elevator, puts Morgan in the elevator along with Faye and I, takes Morgan upstairs to the intensive care unit. He says, you guys sit right here. I'll be right back. Wheels Morgan into the intensive care unit. They intubate Morgan. About 45 minutes later, he comes out and he says, she's fine, she'll be okay, and y'all are welcome to go see her if you want. And in the process of all that, our pediatrician is sitting next to us at this time. And one of the questions we ask him is, are we doing the right thing? And he says, sure, this is exactly what you told me you wanted to do. This is what we're going to do. So this was on a Sunday evening. So Monday morning at 7 o'clock when all the doctors make their rounds, and I think at this point it's really November the 1st on this day. And I guess every month the cardiac staff rotates. So we have a new cardiologist that's going to be in the PICU at Texas Children's. And so when Faye and I walk in there, if I remember correctly, Faye, correct me if I'm wrong, but he was there. And he was an older gentleman with white hair, and he was standing there with his stethoscope and his hands in his pocket, and and he looks at us and he kind of says, I've read Morgan's chart. This is what I think. I understand what's going on. And he grabs her by her leg and he says, and I've already contacted Dr. Frazier, and we have Morgan. He goes, what we're going to do is we're going to keep Morgan intubated throughout the day, or we're going to slowly extubate her, and then we're going to have heart surgery next Tuesday. And so we were like, wow, this isn't what we've heard for the last 2 months. And we started just pulverizing this physician with questions. And he picks his hands up out of his pockets and does this. And he's like, don't shoot the messenger. That's kind of his attitude, right? But what he said to us, he goes, everybody's philosophy is different. He says, mine is the problem is now, the solution's now. So I recommend that we have heart surgery. And that's what we did. And as you can see today, I just showed you a video. Here's this little girl that you can take by the hand who wants to get on a treadmill and walk on a treadmill. I mean, again, it's not the trisomy 18 that's the issue. It's the heart that was the issue, particularly for Morgan. We understand that there's other children with other afflictions and other issues as far as when it comes to trisomy 18 and 13, but for us, this was our story, and here we are today, and we're grateful for the doctors that we have come across, both good and bad. We've learned as parents, how to make decisions that best suit our family and best suit Morgan. And again, it allows her to be the best person she can be. And that's kind of all I have for you.
Thank you, Mark. Faye. So we do have time for questions, comments, and that would be for any of our speakers today. Open for discussion. Colin. Jeff, Dr. Botkin.
Maybe a question primarily for Ben, but one of the things we haven't talked much about is trisomy 1 that gets it down 30 years ago against surgical intervention. I think things changed at that time. Maybe this question, this situation with kids and families with Down syndrome, failure to provide surgical intervention might be seen as much. So the question is there a possibility we're seeing into the same sort of transition for kids with trisomy 18 and 13, and within perhaps some period of time we'll see failure to intervene as problematic in a way that perhaps 20 years ago reading was seen.
Thanks, Jeff. You know, I don't have a crystal ball, so it's hard for me to answer it in an explicit way, but here's how I would answer it, though. I think to the extent that the data that 90% of children will die within the first year of life remains true. Now, that may change somewhat with more interventions, but my suspicion, based on what John presented, is it will change somewhat, but not a lot. That when we think about other clinical conditions in which had even a 60% chance of mortality within a year, we often do defer to parental decisions to either for interventions or non-interventions. So my anticipation is that this will always be an area of parental discretion unless, in general, we learn more about and there's changes in the overall expectations of survival.
But Ben, I think not but, I should say, and you helped us clarify in your last two slides about words we tend to use around, around lethality, around that. And it sort of brought that I'm not sure I'm articulating this very well, but it sort of brought that in my mind. I think the mortality, the survival and mortality differences in trisomy 18 and 13 are much different than I think trisomy 21 was in the 1960s and 70s. But what I'm trying to say is it's still on some sort of line, and you made me think differently about that issue about mortality. So I want to think about that more because I've struggled with that question. Is that where we're going to be? We were that way when I was a pediatric resident in the 70s. It was common to not offer a baby with Down syndrome surgery for duodenal atresia. That was common. It happened in the nurseries that I was in. And so I think it's an important question that we still have to ponder and ask what we are each time. Jan, Dr. Byrne.
Yeah, most of the surgeries are pretty early, within the first 4 months of life. Yeah, so the mean age is somewhere around 3 to 4 months. Yeah.
In the Japanese studies, the first two studies, the mean age was 9 months, and that's what it was in the soft data that Lloyd Tanney and Ann Barnes and I had 15 years ago, it was 9 months, but it's gone down. I mean, like Shaji just said, it's actually gone down to a much earlier time. Question? Oh, yes, Lynn. So I would love this rich discussion to go on. We're just at the hour, so I think there was one other hand up. I think we could take one more question. Yes, Nalangi.
I just want to respond by, there are probably lots of resources on the internet and things like that. But one of the things actually I've been having some conversations with colleagues about is having a concept that we've been talking about, which we're thinking of as, like, for lack of a better word, called like a support team that would be helpful to parents making decisions, whether it's for the surgery or at a later time, regardless of diagnosis. When people are facing issues with disabilities and complex medical interventions, they often are struggling with figuring out what to do. And the idea of having a team that could have people like surgeons, physicians, parents, respiratory therapists, helping them with those things may be one of the ways that we can do that. And that's not, and so not so much as providing interventions or providing treatment, but just helping with decision making that could happen over a span of many, many years. Could be a useful approach.
I would comment that our Dr. Murphy's clinic here at Primary Children's actually provides what you just described, and also our Rainbow Kids palliative care group has really evolved in that direction. So I think just in terms of those models, I think we're fortunate to have those resources. And Nalangi knows that too. It is interesting though how much there is on the internet, you know, for resources that, you know, more than just single kids. But we probably should close. We're 5 minutes after the hour, and everyone. I'm sure that all the participants in our discussion today will still be here for a few minutes, so please join us if you have other questions. Thank you.